I believe we are live, so we're going to go ahead and start. Just to make one small update here, and I did that. Good afternoon, everyone. This is United Medical ACO. I'm here with Sean Donovan. My name is Kamal Arkan, as the chairman of the ACO. This is our weekly event, and we are trying to bring you different topics, different subjects every week. And this week, we also have new items and new guests. Today, we are going to discuss United Medical's collection module with part of the RCM. And also, we are going to have Neuralink campus is going to be joining us. She's one of our senior client managers, and also one of our directors is going to join us, Anthony Anugu, and he's going to explain us the state initiative on the Medicaid health equity. And we are going to discuss the social determinant of health with him. Sean, how are you doing?
I'm doing well. How about yourself?
Good, good. So, we always start with your cartoon. So,
sure. Yeah. So, cartoon this week we have two people getting rid of their masks. Kind of putting COVID behind them, and of course, the woman is saying no more shutdowns except in baseball. For those who don't know, recently there was a disagreement between the Players Association and the owners of the MLB. On salary, I guess, discrepancies. So they postponed the start of the spring ball for the MLB. So kind of ironic because the previous years it was postponed because of COVID. And, now that they're throwing their masks out saying that we're finally, getting past this COVID, getting it under control. Now it's a monetary issue. So kind of ironic there, but that's kind of what's going on in the news for that related to COVID for our cartoon of the week.
Right. So, before we go to the updates on the vaccine and the COVID-related items, so we do want to share. There are a couple of the major days for major months. I guess March is the month of a lot of major things. So one is, and I'm hoping that everything is visible.
Yep.
The National Nutrition Month. So I saw this post from one of our dietitians and would like to share this with everyone. And apparently this entire month is the Nutrition Month. So the second one is World Obesity Day. So this week, actually, the Obesity Week, but today specifically is the World Obesity Day. So there's a small video. I'm going to try to play that. Hopefully the quality comes. Can you guys hear that?
You just have to share the sound. I can see it fine, but there's no audio. I'm pretty sure it was just some upbeat music. I don't think there was any.
Yeah.
So if you're at home, you can imagine some upbeat music with these visuals. So, but yeah, they're kind of just showing. Yeah, they're just showing their approach, kind of different factors that contribute to obesity and kind of the comorbidities that are associated with it, and basically the aim that we're going to address it and kind of tackle it. Especially, like you said, as this being World Obesity Day and the month of March with Nutrition Month kind of coinciding, it's kind of appropriate there that they will address both of those simultaneously.
Sure. So we are going to actually discuss some of these in the Bariatric Friday event. That's going to be in the next 15 minutes. So, all right. So we can go back to our vaccine update. So, Sean, what do you have for us?
Yep. So kind of sticking with that trend that we've seen last week, the numbers are going down. Overall, the U.S. is still not included in that top 5 of cases increase. So that is a good thing for the United States that we are not in the top 5 there. Going down to the cases visually with our one graph, you'll see a super sharp decline with that red trend line that we are definitely seeing the cases much lower. If you're looking at hospitalization records, the number of those who are hospitalized with COVID-related illness are going significantly down. I know in our provider meeting, we mentioned that from week to week, we've seen a few hundred, and then I think last night it was down to like 80 something, maybe like 86. So definitely significant drop off there with hospitalizations and getting those who are testing positive under control. And then vaccination wise, it looked like an increase of about 2 million in the United States over the past week. So that percentage is still increasing steadily. It's kind of slowing down a little bit, but as the more and more get vaccinated, it would be less room for the number to be increasing. So we kind of expect it to semi slow down as we get further in. And then of course, we always have our graph with the Delaware percentages compared to the nation as a whole. And as always, the 65 and over group is leading. And in Delaware, we're now over 93% who are fully vaccinated in that 65 plus age group. And then the total number in Delaware is 62.4% for those who are fully vaccinated.
So the key is, again, I did mention this, and I'm going to repeat myself and repeat myself and repeat myself. So that's what I do since the COVID started. So the key thing is how we are going to prep ourselves for the next flu season. So today is March 4th. So it's spring. The things are going to be better. So the warm weather is coming. People are going to feel better. So then all of a sudden, people are going to feel everything is fine. And then next fall, things are going to go where it started. So that's kind of like what we are worried about. So then that's what we would like to make sure that people are paying attention and getting vaccinated, get your booster, take care of who may need those around you, so that way everyone is taken care of. So I'm going to let Muriel join us, and there she is. Muriel, are you able to hear us and see us? So we didn't see you yet.
Hi, Kamal.
Hey, how are you doing?
Good. How are you?
Good.
Thank you for inviting me.
Well, thank you for joining us. Your office looks like really clean. What happened there?
Well, I tidied up for you.
Very nice. So, well, thank you for joining us. So, as you know, we are trying to do these more like an educational session for our employees, for our clients. So we are utilizing this in so many different ways. We change our format a little bit. So you may be the first victim of the change. So with the different screens running, so we are going to kind of have a dialogue.
Okay.
We have talked about the reporting module, the collection module before. We just want to kind of explain the flow, what happens, why people are going into collection, and what your process is, and you are in charge of the collection module specifically. So what do you have for us?
So I just wanted to just kind of initially summarize what it is. So basically the collections module that we have in specialty practice management, it's a function, and it's a function to capture the overdue patient balances. And it also has customizable features that I will highlight a couple of them based on organizations' preferred criteria. So we're going to some of the features that we in United Medical use and have standardized. There are two items that we have. One of them is the aging feature, and the other one is the payment feature. So the aging feature, what that does is it tells the system, basically when you run the module, it tells the system where to classify the balances, what buckets to put the balances in. And then based on that, you also have sufficient payment definitions or insufficient payment definitions. And I'll go into a little bit more detail on that one. So that's the main thing. It's just the aging feature, first of all. The second, which goes along with the aging feature, is the payment definition. So that is how much of a balance the patient has and how much of a payment they have made towards that balance. And that will tell the system whether to put the account into a collection stage or a pre-collection stage, or whether to just leave the account as is. So those two features really go hand in hand. And that's some of the things that I wanted to highlight and just kind of make sure everyone understands and knows, because you can have a balance that is overdue. And if you make it a sufficient payment based on the system's definition, then you're fine. If you don't make a sufficient payment or you make no payment at all on your account, then that's where you go into the next stages of the collections process.
So this is like just to kind of maybe separate the issue from the collection from the regular billing collection versus this is the self-pay collection. We are not a collection company. We are a billing company. So we are using a third party, but there is still work that we have to do. And then when, I mean, the last thing that we want is to put any of our patients to collection. And then this is the process that we are going through before it happens. So why someone may be in collection, right?
Right. So really the reason why someone would be in collections is that they don't pay their bill. So we send sufficient statements. The patients also receive notifications from their insurances whenever a claim is processed and how much they owe, if they owe anything to the provider. But basically why a patient will go to collections is if they do not contact us, if they receive enough statements and they don't make any kind of payment at all, then at that point they would go into the collections process.
So the other thing is that we do this on behalf of our clients, so we don't actually turn anyone into collection unless we do have their approval, right?
Correct. So we pre-screen accounts. Once the system defines a patient account as being collections eligible, or we also say in the pre-collections process, we screen those accounts. So again, we manually go in there, we review to make sure the patient did receive sufficient statements, make sure that the patient has not made any recent payments. Because if they have made recent payments and they still owe, that's okay. We don't go into the collection stage at that point. Also, we verify to make sure the patients are not Medicaid patients, because we do not send any bills or collections to Medicaid patients. So we pre-screen the accounts that way. Then we send a report over to our clients and letting them know, hey, these are the accounts that we have pre-screened that we see are eligible for collections. Do we have your approval, basically, to send them over to the third party, to the agency? But we do not send anybody unless we get specific approval from the clients.
And the process that you go through right before, if you, with the new format, so it may be a little bit difficult for people to follow. So the process that we go through, so in our practice management system in the SPM, so everything is set up in a way that someone would be identified as pre-collection, right? So, but then you take, with your team, you take those patients and then put them into the collection module, but we use our QuickBase. And then we want to actually provide the most accurate information to our clients. So then whether or not the patient received minimum 2 statements, is it for the same amount, and if there's an attempt to make payments. So those are being all sorted out by your team. So that way we wouldn't make any mistakes in terms of the collection.
Correct. That's why we say we pre-screen the accounts. So the system gathers the information for us. We integrate that information with QuickBase. So in QuickBase, that is where we start our process and we start our work. We start the pre-screening, and from QuickBase as well is where we send the reports to the clients for approval.
Yep. So some clients are not using collection module. Why do you think they are not?
I believe they may just be afraid to upset their patients.
Mhm.
Because nobody wants to go to collections. Nobody wants to be told, hey, you have this overdue balance, it's going to affect your credit score. So I believe that there's that stigma that if you send a patient to collections, they may get way too upset. They might not want to come back to the office. And I can understand that point of view, but at the end of the day, they're legit balances that are due. You're not going to not pay your credit card bill just because you forgot about it, or you think there may not be any kind of repercussions about it.
Yeah.
But I believe that's, in my opinion, why maybe some clients do not want to participate in the collections process. But I also know that there are some clients that, depending on their specialty, they may be more inclined to kind of not worry too much about their overdue patient balances just based on the patient's condition, or again, based on their specialty. But that's what I've noticed in my years in working in the department and my experience in it.
But from the healthy flow of the practice, they have to make decisions for these balances. Otherwise, it just accumulates to a point where we have some clients, they haven't used any collection activities, as you know, and they may be like there may be balances of some patients for 10 years, 9 years, and they need to be cleaned up. So then there's no activity happening, and then sometimes patient gets upset because they didn't receive a statement. Someone in the office approaches them, and then they're like, well, how come you didn't send me a statement? Well, we did, but it was 5 years ago, 7 times. So it's just the system, right? The system needs to be followed. So, and then you were one of the drivers of the initial system that we set up, where we sent certified letters to our clients because we want to make sure that they acknowledge the collection process. They also let us know that this is their choice. If they don't want to use it, we are not going to force them. But we want those clients to have a clean account, and also patients to not have those issues in the future.
Right. I do want to highlight what you just said, Kamal. We're not forcing the clients to do this. So we're not charging extra for this process, for this work. The reason we do it is because we care about the overall client's health. We care about their accounts. We care about their days in AR. So we do this really to help them. And that's why we really, really encourage the clients to use this help and the service that we're offering. Just because, again, it does, if you don't use it, it does impact your overall days in AR.
Mm-hmm.
It makes it harder to collect the balances. After a certain amount of time, after 7 years, you can't legally collect any balance anyway. So if you have accounts that are 8, 9, 10 years old, that's just money lost. Whereas if you were participating in the process, you could have gained some of that revenue in.
Absolutely. And also, just like any other business, so when you go to ShopRite or like Acme or wherever people go, so you go there, and you don't leave those places and not pay, right? So although a couple of times I left a couple of the pharmacies without paying, but I had to come back and then pay. I forgot, so and they didn't stop me. But that probably is irrelevant. So our business is so interesting. People just come in, they have a copay, it's $20. They don't pay. Fine. So now we have to send a statement. So you send a statement for the $20, each statement $1, and then another one, and another one. So then only to get something at the time of service, you spend 15% of that for the statement fees. So then someone goes to collection for $50, and then they get really upset when we turn them into collection. But the simple solution is paid at the time of the service. And then this is when clients also needs to make sure that their front desk is proactively letting the client know what the patient know that what needs to be collected. And then once you have this habit of not collecting, they then become a bigger balance a year later, 2 years later. So, and it becomes a big responsibility. And then you have a specific team to go through these, so that we won't make any mistakes in the process. So that's a lot of work. Now, one thing that I wanted, since you mentioned that when we do this, actually, not necessarily we don't charge or we don't make anything extra, we lose money. Every time you put someone in collection, we actually lose money. How? Because we normally would charge our percentage, and when someone goes to collection, we don't actually charge our collection fee, our billing fee to those clients. So we have no interest in putting someone in collection. So
exactly.
Yeah, that's something that we want to make sure that we highlight. But one other thing, Muriel, since you are explaining this so well, the health of the data and how we can actually compare a practice with another practice. From the statistics standpoint, we lose the ability to compare practices if we don't follow the standards. And the collection is one of those standards, right?
Exactly. It's funny that you mentioned that, Kamal, because I was actually going through and trying to find a case study to show the audience, hey, this is what happens when you use the collections process. But we have very few clients that continually participate in the collections process. So it was actually kind of difficult finding a good case study to present. But yes, it is very important that, once a client does participate in the collections process, they do it on an ongoing basis. Whenever we send the reports over to the clients for approval, it's important that we get that information back as soon as possible, because then you can go months and months without any activity. And again, accounts start piling up. So you never really clean up the account in that sense. But yeah, it's very important for clients, and I want to reiterate that it's very important for clients to continually participate in the collections process for the overall health of the account, and just to make sure that the patient balances are kept at a decent level.
This is kind of interesting as I'm thinking about this. So what the next topic today is with Anthony and Ugu. When it came up, it was during one of our presentations last week. It's the social determinant of health, and it's actually one of the Medicaid initiatives. Now, last night, one of our business development members, Kim Taylor, she presented social determinant of health in our providers meetings. And then I wanted to add that to this session with Anthony's presentation. But when you really think about it, it's kind of ironic that it is the part that makes it more difficult for our providers, most likely, because what we deal with is not like someone comes to you and then buys something. You are providing healthcare. And when you're doing that, in some cases, you can't really just be too harsh to these patients. So then, in an ironic way, then these two topics came in the same session. So if you really think about it, because we are not saying that, because we can't really, there are some patients who really cannot pay, and we want them to come. If you remember our discussion with our patient with the bariatric surgeries, so if they don't follow through, just thinking that they have to pay copay and then they are going to be in collection because of that, we don't want that problem, because that's part of maybe that social determinant of health. In a way, this was not staged, so we didn't actually plan it. I just thought about it as I'm just going through some of those things. So we are going to discuss the other topic with Anthony, but I think that's something that we have to maybe appreciate, so that it's not just the service itself. So what we are providing is probably important. And I think maybe that's the challenge for some of the providers.
Yeah, and I completely understand that. And then also going back to your point about maybe some patients really can't pay their copays or deductibles, or whatever the situation may be. It's important as long as there's some kind of a communication, which is why we manually review the accounts. We could easily just have the system automatically process these accounts, write them off, send them over to the agency, but there isn't that human touch to it. So we manually review the accounts. If we see there's an attempt, patients are calling in, or they're trying to pay up their bill, or they're trying to set up on a payment plan, or they just really can't pay, but at least there's an attempt, there's a communication about it, then, we consider that. We consider that in the pre-screening process. And then,
Very important, actually. Communication is, although these things are all maybe happening, we want that communication from the client. So then we can take the precautions, so then we can make necessary changes in the account. So that's very important. Exactly. Muriel, it's always a lot of fun when you join.
Thank you, Kamal. It's always great joining. It's really fun. I even put on a little bit of makeup.
So thank you.
You can't really tell with the light, but I did just for you, Kamal.
Thank you so much. Thank you,
Kamal.
And we'll, I'm sure we'll see you again in the next couple months.
Yep. Thank you.
All
Bye.
Right. Bye-bye. All right. So I believe Anthony Anugu is going to join us. So I am going to let him in. Anthony, are you able to hear me and see me?
Both, yes.
Hey, how are you doing?
I'm good. How are you doing?
So, believe it or not, I had zero idea this was going to happen between the topic that we just discussed earlier with Muriel. So, because they're independent, like when we are making the agenda. So, but then on one hand, we talk about the collection of the self-pay balances.
Yes.
And then when I think this came up, you joining us for today, it was it the Highmark meeting or the?
I believe it was the AmeriHealth.
AmeriHealth meeting last Thursday, right? It was.
Yes, last Thursday.
So then after that, Kim actually presented the social determinant last night, and that was a really nice presentation. So then I had to go back to some really to prep for this, and as Muriel and we were talking, and I'm just writing some stuff. I'm like, if someone is watching this, so then they're gonna kind of, after we finish this piece, they're gonna be like kind of confused. Okay, on one hand they want to collect, they want to put people in collection. On the other hand, they talk about social determinants, but that's just the nature of our business. We want our clients to know what's available to them. We want our patients to know what they should be doing in certain situations. But this issue that we are going to discuss, before your presentation video, I prepped a couple slides together, which is right now is playing, which I need to take you up here. The social determinant of health is something that we've been discussing for a long time. So before this became became part of some insurance plan, quality metrics, we actually we figured this out. This was a major issue, especially when we started our case conferences. So Donna Gunkel, who spent a lot of time with me in those case conferences, one of the things that we realized, we said, look, I mean, not everyone needs the service the way that we are trying to provide. These fancy, like, oh, you need to have your colonoscopy, you are 50. The person has other problems.
Yes.
So, and I keep saying that, and then because, you and I, sometimes we get hit by clinicians saying that, oh, you're not a physician. Well, we know that, but we are human, and we also know other things. We can see this from a different perspective. And I know people, I know behaviors, I understand the environment, and that's my job to point out some of those. And we actually start engaging insurance companies, case managers, and forcing them in a way to work with us. And if you remember, I was the one who said, look, you need to assign a specific designated case manager for us, and we have to have a monthly case conference, and I believe that's still happening. The main idea was patients, even though they have insurance, they have shelter problems, homeless patients, they have food insecurities, they have other life support issues, environment problems, and we kind of leave those issues and then trying to just focus on the diagnosis. You can't really fix the problem without understanding who you are dealing with.
Yes.
So that's what we want to kind of talk about today. I just want to give the background because your main topic for today is the Medicaid contract. So right now it's playing, I believe, and this new format, you're kind of used to it now, so you're following these very closely.
Yeah. Yeah. The one of the things that and you're absolutely right in the sense that some of these issues we've been dealing with for a while, and they're not necessarily new issues. The impact of social determinants has been well known, right? However, one of the things that happened with the COVID pandemic was that it sort of shone a really harsh light on the healthcare system and exposed it in a way that's almost brutal, the fault lines within the healthcare system. So you had situations where there was a disproportionate mortality rate in terms of COVID mortality between Blacks, Hispanics, and whites, like 3 times more African-American deaths, and more than double the number of deaths that you saw in the white community. And what these did was really expose some of the disparities in the system in terms of healthcare delivery, health outcomes, and so on and so forth. So it became almost inevitable that post-pandemic, to the extent that we can speak of post-pandemic at this point, had to begin to look again at these issues and see what is the best way of addressing the issue of health equity. Health equity being a total approach to health, one that recognizes equal outcomes irrespective of race, ethnicity, and so on and so forth. And to see how new models can be developed to better address these. And they're not often very simple questions to answer because disparities can come as a result of inbuilt inequities in the system. For instance, when you roll out telehealth waivers during the pandemic, right? Mm-hmm. It improves access. Technically speaking, it improves access. However, the access is determined by other issues. For instance, access to broadband. Mm-hmm. So if you're in a community with low or no broadband access, then of course you don't have access to telehealth. So the waivers don't mean anything really in that effect. So it became necessary to begin to look at some of these issues again and to see how to better address them. On the CMS side of it, CMS started now to talk about changing strategy as a whole in order to better incorporate issues of equity and to better able to measure these issues. And the starting point for CMS was what they launched just last week, what's called the ACO REACH, REACH being Realizing Equity, Access, and Community Health. It's the next level of the old Accountable Community ACO that they tried to launch several years ago. And together with Medicaid, they're looking at really two main approaches, right? How to incentivize groups, ACOs, health systems to better manage the social determinants of health, and then how to incentivize those same groups to address disparities in healthcare, to better address health equity. But always the challenge is in determining what is the appropriate measure. What is the appropriate measure to capture these? And the starting point always is in, first and foremost, identifying, creating streams of data to be able to identify first and foremost, what is race, what is a patient's race and ethnicity. That's typically the starting point. And that's what we're starting to see now in the new Medicaid contracts that are being rolled out. The first one is that we see is the one with AmeriHealth carried as one of the managed care organizations in the state. And you may not know this, but the state of Delaware had a request for proposal out at the beginning of December. And one of the items that they embodied in that request for proposal for MCOs is that they identify clearly how they intend to address the issue of health equity, how they intend to address the issue of social determinants. That's what we're starting to see now with the first Medicaid contract that we've received, which is the AmeriHealth Caritas contract.
Sure. So just to kind of put it in perspective, and I think the video that Kim shared with us last night was right to the point. So what we are discussing with the social determinant family, like a single mom with two kids, taking care of her mother. And she has herself, the single mom has diabetes and other chronic illnesses. And what this provider was explaining is she's able to take care of everyone else, but by the time it's end of month, she's not able to eat properly. And she's able to take her medication, but because she's not able to eat properly, then certain things are not working out anymore. So then things are alarming. So that's kind of, and then when you try to approach her, why is this happening while you're taking your medication? Now they are on a defense.
Yes.
And then this is not understanding, like not understanding your patients, not understanding what's happening with this person. So this is why I'm saying that this is not about just from the clinician, just because someone is a clinician doesn't mean that they understand exactly what's happening with that person. Understanding the behavior, understanding the social environment of the person, knowing who we are dealing with can actually help us to customize how we are approaching them, how we are asking certain questions. And if we can actually make certain, without maybe hurting their feelings, if we can make them make certain things available for them. Because many people, Anthony, as you know, many patients don't know what's available to them through their insurance plans. And
yes,
utilize them, like transportation is one of them. This is free service for Medicaid patients, and it's available, but they are not being promoted, unfortunately enough. It's the Humana as a Medicare Advantage plan. They do have some food services available. They can actually participate, and then they can actually plan better. medications and others, these are all available. So I think between more education and community awareness of it, which we have to, I mean, we don't have a choice. We can make this better. And I'm hoping that that's where we can get to. Now, where is United Medical ACO with the Medicaid ACO contract?
But as at the beginning of this year, we are, as far as the state of Delaware is concerned, we are a Medicaid ACO because we successfully applied. Our application was reviewed in 2021 and it was accepted. And that then enables us to contract with the state managed care organizations. In this case, it will be Health Options and AmeriHealth Caritas. And because we're in this program, the contracts that we then sign with these two managed care organizations has to be in compliance with the program requirements of the Delaware Medicaid ACO. That's where we are at the moment. We are in process of finalizing the contract with AmeriHealth Caritas. The Health Options one is still in the process, and there are several issues that we are still discussing on that side. But the first one that should come on stream will be the AmeriHealth Caritas contract. Quickly, one of the things to point out here is that what some of these are requiring us as an ACO and our providers to do is to, for instance, typically in the charts, every patient's chart identifies the certain social demographics of the member, its level of education. And essentially what this whole thing is moving towards is asking the provider, as part of the routine care, for instance, to recognize the patient's level of education and bring that into bear in how you discuss the patient's medication, for instance, right? How aware is the patient of the prescription drugs that he or she is expected to take? Why these drugs and why not the other? Does the provider recognize that one drug may be too expensive for this patient because of their income status? So the income status of the patient as reflected in the demographics in the chart, for instance, the patient's level of education, all those come into play in medication management and by extension, the patient's compliance, because you would expect that the better they understand the provider's thinking behind a particular medication, in other words, the why of that medication, then the better they are able to comply with some of those clinical guidelines that follow.
But so that's, that goes back to the same issue of the time that providers have with the patients. So our approach from the central business office with care coordination with our nurses and putting a lot of information and a lot of communication with the patients to understand certain things and then alerting the provider probably is helping.
Yes.
We have so many standard letters that we put in the system, so like we can actually improve those and make new ones to address some of the issues to close the communication gap. But I think some of them needs to happen outside of those visits, because providers are also right when they don't really have a lot of time to get into those details. But if you are able to prep the patient, if everything is available in the chart, I'm pretty sure we are able to achieve the same goal. So that's what I see. Well, Anthony, thank you for joining us. So this was beneficial and helpful for me personally. Just talking about these things, I feel better because I know people are listening and then they can actually understand what we are going through. So thank you for joining us.
Thank you for having me. Yeah.
Right, so Sean is gone. So like I don't know what happened to him. So he was. Sean, we're gonna be gone for the whole time.
I'm here.
We're taking a nap. You're in my office, right?
Yes, I'm still here. I'm listening.
So how are you doing now?
I'm good. I'm good.
So like last week, here's the thing. So all these different stuff that we are talking about, I'm actually going through, like personally trying to make sense out of these.
Mm-hmm.
So one is, so I think your light sensor is off again. So it's the one, like.
I think that's in your office there.
No, it's like it's on the other wall, like in front of you.
Straight ahead. Let's see if I get up and I walk maybe into your office. Let's see real quick.
Okay, there we go.
All right.
So the issue that I think these sessions, here's the problem. So last week we discussed what's happening in Ukraine and Russia, the war. And this week we talk about like a collection module. And then this week again, we talk about the social determinants. So, and then this week, we are trying to, address the issues to see how we can make this community better while we are actually seeing a lot of people are being killed on the other side of the world. So, like so many like crazy stuff all together, and it is difficult to process. As the office knows, like I'm trying to keep the dog alive. So, and then on the other hand, then you see the hundreds of thousands of people are being displaced from their home. They're being killed, and we are still trying to do our job. So this is not easy. Coming out of the pandemic, we didn't even come out of the pandemic, but just trying to come out of the pandemic and not seeing why people are not, why we have to be at the mercy of these people, and people not understanding the seriousness of the problem is concerning.
Yeah, and obviously, having the pandemic and then this, like you're saying, without really having a breather in between, kind of one thing after the next, and like you're saying, the seriousness, and hopefully that doesn't, exponentially grow in the severity and how dangerous, ultimately if any of the next steps are taken. Obviously, we're trying our best to avoid preventing certain issues, from arising to a further extent. It's definitely an alarming situation.
So, many people are having issues these days just to adjust the pandemic situation already. So we see this with elderlies, we see this with people who are trying to make these adjustments between work and the home, kids with school, if you remember, not to necessarily defend Dr. Oz, but just to try to listen to what he was saying. He had a point when the little kids were forced to wear masks at school. And they were like, "Oh, I like your mask better, so let's switch." So then and they keep the mask for like 8-9 hours throughout the day, which is not healthy. But the way that he was saying, you don't want to pay attention. But what he was saying, there was a point. And all these have mental weight on people, on us, on societies. And so we probably need to take this seriously. And now this war is putting a lot more stress on people, and we do need to figure out, how to make this least impactful for our societies. So, and I don't know what the right answer is, but we'll try to keep doing what we are doing and try to touch more people's lives. Hopefully, we can do better. Now, Sean, I did want to go into our book.
Yeah. Speaking of wars, again, not planned, very coincidental, but this was up next in our rotation. The Art of War, Sun Tzu. We did not plan it, but obviously many valuable lessons in that book. Like in a lot of the books we presented before, they can be attributed to business, education, social relationships, your communication with others, and a lot of the principles in the book can definitely be applied, in various.
So this is the book that we are talking about here.
Yep.
Now, so what I was trying to do with this one, so I'm hoping that everyone can see it properly. So the, just to see how this Russian-Ukraine war happened and then what mistakes were being made, how it impacted both parts. And this book is so old, but yet still is applicable to these situations here. So I was trying to kind of make some points for us to be making some direct reference to the book from the current situation. And perhaps we are able to do that maybe next week. But this is what we are going to discuss with the 13 chapters of this book and how it applies to today's Russian war and the mistakes from Putin. I guess we are going to say what mistakes were being made and how we can what lessons we can take.
We can definitely look into, like you're saying, some of those underlying themes there of the book. And as you mentioned, in the book being so old, it's, not a coincidence, but these principles are still coming up in the events we see in current day. So
this was on our agenda for more than a month now, so we just didn't have time to bring it up. And then there's Russian war,
so we waited for a war to happen before we wanted to.
Yeah, right. So we have nothing to do with it.
Right.
Well, so it is almost 3 p.m. So we have the Bariatric Friday coming up. So we'll be back next Friday. The 2 weeks from now, our state senator, Sarah McBride, is a confirmed guest. She's going to be with us. And next week, we are doing the clinical event presentation with diabetes.
Jacob, yep.
Next week, we have a lot of events. Now, we forgot to mention the Colorectal Awareness Month, and then we have a special presentation next Thursday with Dr. Sachin Wade. So that's already posted on our YouTube channel. So next week, there are so many events, so we'll be able to catch up.
Like you said, March is a busy month. We got everything going on in March, so tune in.
Thanks so much.